I'm Paul Jarvis. I'm a consultant in emergency medicine. I'm the other kind of consultant. I'm a medical consultant. I'm a doctor. Emergency medicine, some of you will know it as accident and emergency. Some of you know it as the emergency room. Those of a certain generation will know it as casualty. And some of us know it as chaos.
It's chaos.
And I kind of changed the title of the talk. This is basically a journey that we've been on, and this is what I hope to show you is the results of an experiment we carried out, which we aim to take live towards the end of this year. And then I want to share my views on what it's like with lean at the coalface as a frontline clinician. We had a problem. 80% of our patient complaints were about waiting. Patients don't like waiting. Yeah. And we had a lot of complaints. We were struggling to meet our national access targets, one of the awful list of targets that Marc has to shout at me about. And we were hemorrhaging staff at an alarming rate. We had staff burning out. Our senior workforce were just leaving because it was becoming unmanageable. You know, the trigger for me to get involved in this project was when one of the senior sisters sat in my office and just cried because she couldn't take it anymore. So something was fundamentally wrong with what we were doing. So I did a course. I went to the LEA and did the Making Hospitals Work course. And that was certainly a catalyst in my career, my interest in service improvement. So when I got back after doing the course, my first job was to look at what we actually did. How many patients actually attended the hospital, well, the emergency department, and when did they attend? Because do you know what? I've worked in A&E for 12, 13 years. I couldn't tell you. I just turned up, saw the patients, went home. This is an average day. We see about 180 patients per day on each site within the trust. This is just one site's work. And surprisingly, no one comes into A&E at 5 o'clock in the morning, unless they're really ill or not right. And it trundles along sort of slowly until around 10 o'clock in the morning, and then all of a sudden, a bus arrives, everyone gets off and goes to A&E. It stays at that level, really, till about 2 o'clock, and then there must be something good on television, because there's a dip around about 3 o'clock, only to pick back up again at 6 o'clock later that afternoon. And it stays at that level throughout the rest of the day, really, until midnight. And as I said, I've worked in 12 different emergency departments, 13 different healthcare providers. And this is the same everywhere. This isn't specific to us. This problem is everywhere. I've even worked in Kenya, and it's the same. The numbers may be different, but the distribution is the same. And what I then did was look at how many doctors we have on at the times throughout the day, and worked out how many patients a doctor can see per hour, and look how big the queue would be if we didn't get on top of it. And during the night, when no one comes, we're fine. Soon as that big surge happens at 11 o'clock in the morning, the queue starts. And we just grow, and the queue gets bigger and bigger and bigger and bigger, until when the next surge happens at 6 o'clock, we've now got 30 patients waiting to see a doctor. Now, patients aren't widgets that you make in a factory. We're in a rather unusual position that our product is also our customer, which is very strange, because it offers a whole line of different dynamics. And our customer, patient, product, whatever we call them, if you ignore them, they sometimes get worse. If you ignore them, they sometimes die. That's bad, far too much paperwork. Or they just get up and leave and don't tell you. So wherever there is a queue in healthcare, but particularly at the sharp front end, there's a clinical risk. And so this is clearly unsatisfactory. And so from this data, it's clear that we're unable to meet the demand from 11 a.m. After doing the LEA course, I was introduced to the whole world of tact time, which I tell you is a complete novelty as a clinician. And it's quite clear that from 11 o'clock onwards, we need more time and more doctors. And at the moment, we just don't have the capacity to see the patients we have. And this is just an average day. The variation we see in patient numbers can be as much as 50% extra with the same number of doctors seeing them. So clearly, it's not satisfactory. Now, this system is what exists throughout the UK. It's the same one I saw in Kenya. I suspect it's very similar to the one you see in the States and elsewhere in Europe. You have two ways into the system. You can walk in, or you can come by ambulance. If you walk in, you go through reception, you see the nice clerk who takes your details, and then you sit and wait. And you wait to see the triage nurse, and you think, yes, I'm getting somewhere. But the triage nurse's job is to decide how long you have to wait, which just seems daft. Next, you could come in by ambulance. Sneaky coming in by ambulance, because you jumped the queue. So you've got two ways into a system, and they don't have parity. Whichever way you come in, you're going to wait, because the system's designed to make you wait. Finally, you get to see the doctor. Yes, you think, I've seen the doctor. Marvellous. This is going to be good. He's a junior doctor. He's doing his best. And he orders a whole host of tests. And they take time. And then when the results come back, which takes even more time, you see the same doctor again when he's free. He looks at the results and goes, oh, I don't know. So he then finds the nebulous consultant, me and my colleagues. I'm not the only one. And the consultant goes, well done, you've done a good job there, son. Let's start some treatment. And then we've got a decision, do you come in, get admitted, or do you go home? At every stage throughout that process, there is a wait. Sometimes that wait can be as long as an hour between each phase. That would upset Marc, because that breaches the access target that we have as a maximum of 4 hours for the whole journey. So the old system is designed to make you wait. We've got stupid steps in it, like triage, which offers nothing other than you're going to have to wait this long. You've got two competing access points, and if you come in by ambulance, I'm not seeing any healthcare just phone an ambulance, that's not what I'm saying. But if you come in by ambulance, you will jump the queue, which upsets the people in the waiting room. The investigations are requested late in the process, and as a result, it takes more time. There is a potential for inexperienced staff to order unnecessary investigations, and so when the consultant gets to that patient at the very end of the process, you realise the wrong tests have been done, there's a whole heap of rework that's got to be done, further delay in the patient journey. So it's not great. And it's not just our trust, this is national. So we set about redesigning the service. So we removed triage, because that just seemed pointless keeping that. Okay? It's not value adding, get rid of it. We moved investigations forward. That makes sense. We standardised the investigations, so the doctors and the nurses had a panel, so if you came in with chest pain, the nurses could look, I need these bloods. The right tests are done. And you move the decision maker, the senior doc, to the front of the process. So you're quality controlling that process. That's what we did. And this is what we designed. There's fewer steps. There's still two ways in, but now we've got something called EDIT, not triage. EDIT stands for Emergency Department Intervention Team. Because we realised if you came in not by ambulance, you waited, and you could wait 3 hours to get to the doctor who's then going to order the tests, that was daft. The EDIT team, which is a nurse, or two nurses, do the same thing that would happen to you if you came in by ambulance. So you have the same investigations as soon as you arrive. How cool is that? We did a patient experience forum, and this old guy was brilliant. He just went, you know that stuff you do? Yeah. Do it at the beginning. The patients could see it. We're stuck in the middle of this going, no, this is the way it's always worked. This is how it works elsewhere. So now if you come in by ambulance or you walk in, you get a very similar patient journey. When you see the doctor, he's already got your results, so you only have to see him once. The consultant is at the front end. How brilliant is that? So the person who can make the decision, the bloke who's assuring there's good quality going on, is at the front end. You can agree a treatment plan, and then you can decide whether they're coming in or going home. So this is EDIT. We like EDIT. We did make some staffing changes. To make EDIT manageable, we employed 2 extra nurses working from 10 in the morning till 10 at night. We also had an additional middle grade doctor, and that's somewhere between a trainee and a consultant, so it's more experience. And we put those in the busiest part of the day. So 1 extra doctor per day, 2 extra nurses per day. Now, this bit sent my general manager almost over the edge. Big improvement project, and we did nothing for a month. I say nothing, we didn't change anything for a month. We held breakfast meetings. Now, if any of you work in healthcare or plan on working in healthcare, if you want people to listen to you, you're going to have to supply food. Okay? Chocolate is the gold standard. If you're failing chocolate, cake and donuts is second. Okay? Anything, fruit, only the cardiologists do fruit. Those working in health know exactly what I mean. So we held breakfast meetings, and we did them over a month. And we made sure every member of staff, before we meddled with anything, knew what we were doing. And we let them have their say. And we let them say, that's brilliant, or have you thought about this? And can we just change that a little bit, because I think this will work better. So much so, some staff came in on their days off to come to the meetings. Others, once they'd been to the meeting, came in on their days off so that their friends could go. That's how much the staff wanted change. And that was just astonishing. People came in on their days off. You know, people with young kids at home came in on their days off to make sure that their friends could go to a meeting. And all we did, we explained there really is a problem, and we showed them we'd actually looked at it. We went through the nature of PDCA and what it means, and we also stressed it's not going to work first time. At the moment, we've got square peg, round hole. If I'm honest, right now, we've got oval peg, round hole. It wasn't met with widespread open arms by everyone. There were cynics in the group. Some of the hard-nosed ones said, you're just trying to change our work pattern. We don't like that round here. I'm not from Yorkshire, so I can do that. Some of them said, you're making us do more work. And it spent me hours going, no, I've just moved the way you're doing it. The standard response in healthcare, to get results, you're going to have to put at least £1 million in it, and then you might see some improvement. Nonsense. And my favourite, I'll try it, but it won't work. Yeah, I'm sure in whatever industry you've worked in, you've heard virtually all of those. The vast majority of staff were just so pleased that someone was listening to them. Someone was taking time to go, this is a problem, and I'm on your side. And they just so happily wanted to embrace it, and it gave them ownership. These are our results. The time to the first clinical contact. That is when you meet that nurse. So nothing has happened at this point. You've not had any intervention. I don't even know what's wrong with you. You're just a person who's booked into the emergency department. You could be having a heart attack. You could have a bad case of projectile leprosy. I really don't know what's going on. Okay? That is so unsafe because I have no idea what's wrong with you when you're in that phase of your journey, because you've just booked in, you've walked in off the street. And we've shown by doing EDIT rather than doing triage, we can break the median time for that first contact from 30 minutes down to 9 minutes. 9 minutes is much less scary to me if you're having a heart attack than 30. okay? Hopefully, you'll be spotted even quicker and we'll get you straight in with your heart attack. I'm not saying we've got it right. Some days we still struggle. Our 100th centile was 1 hour 50. That's completely unacceptable. But the patient did go out for 3 cigarettes and no one knew where they were. But our 95th centile is 13 minutes, which when I saw the figures was astonishing. Compared to the 1 hour 30, nothing's happening, you're just waiting to be told you're going to have to wait. So not only is the time to the first contact better, the quality of the first contact is better. You get pain relief straight away. You get your bloods done straight away. You get put into that system so that you are getting healthcare as soon as you arrive. It's vastly statistically significant. We also looked at the total patient journey. So that's how long each patient spends in the department. And again, these are median figures for particular days. We reduced the patient journey by over an hour. Not doing any extra work, just changing the order we did it in and having 2 extra nurses and 1 extra doctor. There wasn't a £1 million investment. Yes, it did cost some money, I'm not going to lie to you, but it's made such a big difference. Still had to wait 9 hours before being discharged. That was a very sick patient that was too unstable to move. That's life, that's the real world. I think someone said earlier, welcome to adulthood. Yeah, that's where I earn my money, looking after the really sick ones. But we've made good, lasting, sustainable change. The number of patients that leave without being seen, in other words, they got fed up of waiting, so just up sticks and left. Statistically significant. It's down. So the customers are happy. The staff are so much happier. The effective edit upon frequency of patients reattending. In other words, if we're kicking them out quicker, are they just coming back the next day because we didn't do it properly? No different. So we've made improvement, not just change. It seems to be sustainable. Patients are happier, the staff are happier. The staff are happy for many reasons. Having the consultant at the front end rather than the nebulous figure wandering around, if you want him to be there, sort of dabbling at the back end of the patient journey. It boosts morale. It encourages training. You've got a senior doc working alongside the juniors so they can learn by role modelling. It's so much better than the get on with it, I had to drown a few times before I got it right, which is how medicine's been taught in the past. Who would have thought you could make so much difference with so little investment? Do you know what? If you remember nothing else that I say, lean works in healthcare. So my personal views. Some of you will be hospital managers, and you'll be saying, yes, but you're not normal, Paul. You're not the normal clinician I come up against. They're all hard-nosed, angry, cynical people who won't listen, who know best. I don't know that description at all, honest. They exist. But what you do is no different to what I do to every patient. I assess them. I get a history examination, get some investigations. If I've got a problem in a department, I do exactly the same thing. I make a diagnosis, I treat it, I reevaluate. It is no different. That's how you get clinician involvement. What did I learn? Time spent winning hearts and minds before any change is really well spent. That month, before we did anything, although Bev, my manager, almost went over the edge, it ensured we had buy-in, it ensured people were wanting to deliver, and ensured people were all on the same hymn sheet. My organisation took a big punt on me. I was a junior consultant. I'd only just joined the trust. And they let me do this without knowing much about my background or what I'd done before. And I'd had no experience in service improvement at all. It's not taught at medical... Well, I'll change that. It wasn't taught at medical school anywhere in the land. It's now taught at Leeds based on a module that I've written based on my experience at the LEA. We need to have more... staff involvement at the coalface because the patient told me the answer. The staff knew what the problem was. Okay, it's not rocket science, the solutions. We just need to start listening to our troops on the ground floor. The other thing that helped is our manager being visible, listening and supporting change, but also being the voice of reason when I have far-flung ideas of world domination. Misprint on this slide. Healthcare doesn't need change. Healthcare needs improvement. If you speak to clinicians, there are some fantastic, fantastic ideas out there, but they don't know how to implement them. Okay? And so they flounder. Traditionally, the senior doc would have a great idea, implement it, and ignore it, and carry on going with it, even if it was falling around them, because that's my change, it's better, it's much better because it's my idea. Yeah? Healthcare's full of this 3I methodology: idea, implement, and ignore. We've got to move away from that, yeah? PDCA. So, from the three of us, these are kind of our key points. This isn't a one-off change event. This is a 3 or 2.5, 3-year journey. It's just to get this far. The things we struggle with, when the going gets tough, there's a tendency to go back to how it used to be. Yeah? It makes people cry, but it's got to be better than change. My advice to you is, if it's going to get tough, keep the faith. Next biggest job I've got on my hands is convincing colleagues, both clinicians and managers, that operational management is necessary. Because, as Dan said, it's not in healthcare. And also we need to break down the clinical silos. Because no one works across the hospital for the patient. They work on behalf of their team. And it's not good enough. Thank you.